Good morning, everybody. Thank you for coming. I'm Stephen Maier. I know some of you, and I don't know a lot of you. I would love to meet a lot of you, but thanks for having me. Thanks for coming this morning. I am going to talk to you guys about how I do an ACL. I use a quad tendon allograft. It's a soft tissue graft that is suspended with button fixation on both sides, and I will tell you why I do this. This is my mentor, Dr. John Zaroyans. Everybody calls him X. He's the guy who basically invented the technique that I use and all the equipment that I use. He works pretty closely with Arthrex, so I use an all Arthrex construct if it matters for anybody in the room. I do not have any disclosures. The initial interest in quad came from a couple of reasons, as I'm sure you all are aware. The BTB graft leads to a lot of anterior knee pain in a particular population. Say a third of my patients who I've done BTBs on will come in with anterior knee pain. A number of patients who have had previous BTBs will still come in with complaints of anterior knee pain. So the quad graft avoids that. We don't take a chunk of bone off of the patella. The incisions that I use are very small, so the cosmetic appeal is slightly better. You don't have to use this big arthrotomy-looking incision along the front of the knee that may lead to some arthrofibrosis. In terms of hamstrings, the hamstring data now is pretty clear that in particular populations, the data is showing failure rates are much, much higher. So I have steered away from hamstring. Like the last hamstring I used was in residency a long time ago. So I've never done one in fellowship or as an attending, and I don't plan to unless I have to. And then allograft, you just really don't know with allograft what you're getting. The data shows that in older patients it's fine, but in younger patients the failure rates are higher. So we just try to avoid failure at all costs, and that's why I go with the quad. The quad's an all soft tissue graft. It does not take a piece of bone. It doesn't lead to anterior knee pain. The only thing that I get worried about in my grafts is arthrofibrosis from a big graft. And some people in the room have seen my ACLs. The only concern I usually have is getting full knee extension and activating the quads. That's the first steps in getting somebody ready for a recovery. In terms of the anatomy, comparing quad versus patellar tendon grafts, you do get the same length graft, but the quad offers a greater fibril to interstitium ratio, so you get like a lot more substance with this graft. The fibroblast density is higher too, so you're getting more collagen per square unit. I've gotten MRIs after some of my ACLs, and you'll see that this graft is like substantial. It fills the notch, it's robust. You really have a really nice Lockman, but you'll see that the difference in MRI substance is secondary to these things, which has been shown in the literature. This is what it looks like macroscopically. So you're looking here at the quad tendon, VMO, vastus lateralis, and then deep to that are rectus and intermedius. And then in cross section, it's pretty robust. So you can see that there's some really nice thickness to this. It will fill the notch, it will fill your tunnels, and give you a nice stable knee. Reliably, you will have 5 to 7 centimeters of really nice tendon, and after that it kind of dwindles, but then you can kind of shape it the way we used to do with hamstrings, and it becomes a really nice looking graft. Biomechanically, the numbers of a quad tendon mirror the numbers of a native ACL. And you'll see that the BTB, it has a slightly lower ultimate load to failure, but the modulus of elasticity is greater. So it's a stiffer graft, but it will fail sooner. For me, if I could put on a new ACL, it would be the old ACL. So I'm just mirroring the numbers that the native ACL has shown in the literature. So I harvest typically 10 millimeter wide grafts. This study harvested 10 millimeter wide grafts, and they compared the strength of the quad tendon after harvest to the strength of a normal patellar tendon that's intact. I don't know why it keeps doing this. But what they found is that the post-quad tendon harvest strength was actually superior to the patellar tendon intact strength. So in my mind, it goes to show you that taking somebody's quad tendon does not lead to inferior outcomes after harvest. and it's predictable. So I didn't say this earlier, but in hamstrings, you have no idea how long you're going to get for your grafts. You have to triple it, quadruple it, quintuple it, and it makes you nervous as a surgeon because you never know if you're going to get enough length to fill both of your tunnels. Whereas in quads, you are reliably getting what you need. So we'll go through some simple math that I use. I'm not a very complex mathematician in the operating room, but I do like to know that I'm going to get enough graft to fill tunnels and to satisfy what I need in the notch. And as you can probably imagine, taller people have longer grafts, but you don't ever have, even in short people, an inferior length graft. This is just another macroscopic anatomic picture. But the quad tendon graft, as I said, very, very robust, very reliable. You get you get about 7 centimeters of length every time. 3 centimeters proximal patella, so mid-substance of the quad tendon. There's very little variation, and it's almost always the same size. And that size is almost 2 times the thickness of your patellar tendon. So I keep reflecting on the same concepts because I think they're the important things to compare between grafts. And then it's also useful in kids. So if you're ever doing a pediatric reconstruction, you're not taking bone away from an area that is an issue. You're not putting bone across an area that you don't want to cross. And the length is always reliable and the thickness is reliable. So it's a graft that can be utilized for all populations, tall people, short people, young people, old people. And you're getting the same type graft every time. This is what it kind of looks like when it comes out, but I'll show you some videos so you see. But this picture is just to show you that you can go thin, you can go thick, you can go long, you can go short. You can use as much or as little of the quad tendon as you need or want. And it comes out looking fairly similar every time. What do we do with this information? We compare it to what is considered the gold standard, and that is the BTB, even though I do think the quad tendon is going to be very soon the gold standard in addition. This is my simple math. So optimal length of an ACL graft is between 6.5 and 7 centimeters, and that is because a native ACL is on average about 25 millimeters long in the notch. I would like to have at least 2 centimeters of graft filling tunnel on each side. So 2 plus 2 plus 2.5 or 3, just to be safe, gives you about a 7 centimeter length graft. Now, again, comparing quad and patella, if you're looking at volumetric differences, this is what I'm uncovering, is the only thing that's different. You're using the same length, same width graft, but the difference is that depth or that thickness. And if you're talking about 2 times difference in quad tendon thickness, you're talking about a much more substantial graft that fills more volume in the notch. This picture is basically a simple way of saying that the all soft tissue quad fills all of your tunnel, whereas the patellar tendon has a piece of bone that fills some of your tunnel, and it's very difficult to contort perfectly cylindrically to fill all of that tunnel. So you're getting lots of graft in quad and mostly graft in patellar tendon, but a lot of bone, and then you have some areas that are not contacting tunnel walls. So lots of info. This is my kid.
That's Stevie.
This is Stevie. It's my little boy. And this is him again. And somebody else is running the show right now. These grafts, I think harvest time, I mean, it probably doesn't matter to you guys, but it matters to everybody else in the operating room because when I'm in there, I just feel people breathing down my neck. So for me, a quad tendon graft can be out and closed in about 10 minutes. Patellar tendon requires a little more finesse. You don't want to crack the patella, so you have to take your time around that. Is there a way to slow, but I don't use them any longer, so I don't even bother with that. But the quad tendon, you can get it out fast and easy in a pretty small incision. So I'm just going to go through my technique, what I use, how I do it, and there's a lot of videos here to show people how it works. The instruments that I use are all made by my mentor, X. This is, the top is the quad blade, the bottom is the cigar cutter, and you're going to see how I use all of them. So the graft knife is a custom width dual blade knife that has a handle that allows me to project through a very small incision approximately without having to expose the entirety of the quad tendon. You can get different sizes, so I'm doing a quad today in a guy who's 6'4". I'll probably use a 10mm graft on him. I had an athlete who's younger. I use a 10mm graft on her. I've got a small girl who I saw in clinic the other day who I'll be doing probably soon. I'll probably use a 9mm graft on her. Rarely am I using 11s. 11s feel a little bit too much notch, but if there's somebody who's very big and they get in there and the notch is very wide, then I would use an 11. The nice part about this is the depth of these blades is 7mm, so the concern would be you don't want to plunge and hit cartilage that's deep to quad tendon. You actually can't because the quad thickness is deeper than what the depth of this knife is, so you're getting almost like near full thickness cut with your graft knife, and then at that you have to complete the cut with a deeper knife. It's low profile, so I can sneak it in through a small incision, and it has sharp sides on 3 sides so that it's got a beveled blade. And this is how we prep it. In training, this is how it was positioned. I don't do this because it's got a big setup associated with it. I just do it on the table. It's a lot easier. It's still easy to harvest. But the knee has to be able to get to 90 degrees of flexion. It's on tension, it's harvested in flexion. It gives you like a really nice counter tension to apply your force to, and it applies its force back to you. And then I mark everything in flexion. I'd say this is probably the only controversial thing that I do. Everybody else probably does it the same way, but I make a transverse incision. I find that a transverse incision heals well, it leads to less scarring, it's more cosmetically appealing, and it's in Langer's lines. You don't need to retract anything. I can get a single retractor in there and see everything I need to, and all of my work is done through that, and I can see as far proximal as I need to. The key to seeing everything, though, is to expose everything deep to it by removing fat. So people are concerned that you take out a piece of fat and somebody's going to have this big dimple, but I don't think you've seen anybody dimple yet. So I take out a lot of fat, so that basically just subcutaneous tissue beneath the skin, no fat hanging, and then I stick my scope in there. And the scope allows you to see everything together. So you make a transverse incision, take out your fat. As the fat comes out, then the deep fascia will come up in your face. The deep fascia looks a lot like the quad, so you have to be a little concerned, but as long as you know what you're doing, it's pretty safe. Once you visualize the donor site, then you stick the scope in. So everything I do is arthroscopically because it limits the amount of incision I make. So I make like a thumbnail size incision above the patella, and I can see all of the graft that needs to come out. Oftentimes the limitation in this and the size of my incision is the cigar cutter, the actual instrument you're going to see in a minute. But I have done this a number of times where I've made my incision so small that I actually cannot get my instrument inside to get the graft out. So it just kind of a representation of how small it is. Once you're in there, you're going to start seeing the convergence of VMO and lateralis, and that apex is what you're shooting for because you want as little muscle to be traumatized and damaged as possible. I mark on the skin outside of the body where that apex is so that I know exactly where I need to take my path with my graft knife. Once you know all those landmarks, you have an idea of 1, length, 2, direction, and 3, how to take care of the rest of the procedure. So at that point, you're ready to excise the graft distally. I use just a sharp 11 blade to come down right on the patella, release the edges that have already been marked essentially by your graft knife and complete them, take it off of the patella, and then you get a little, I don't actually do this step, but once you get the end exposed, you put a little clamp on it, you can get a suture around it, and then you have really good control. And then again, this allows you to get around the patellar tendon so that you need to do the work to get it out. This is the quad blade. I guess it's not going to work, but here we go. In action. So quad blade working, and this is the amount of view that I have in the operating room. So I mark VMO, I mark up here the apex of where that convergence is of VMO and lateralis. I know exactly what my trajectory is. I slide my blade in, get it under the skin. I've already released the fascia so it doesn't get hung up. And then you go up high, and you get as much as you need. And I only say this here because I think as a surgeon, the things you want to be doing are the right things without really questioning yourself. And like, if you have all of your markings made, there's nothing to be scared of. So you can just go at it with confidence. I close all of my graft sites. I take a full thickness graft. It's nice and robust. It gives a really nice cylindrical graft. It's called a scorpion. It's an instrument that if you squeeze the handle, it self-passes a suture, so I will throw a suture around the neck of the scorpion, create a little luggage tag, and that allows me to actually not have to throw a knot superiorly. The way we used to do it is you get a suture in up high as you can, then actually have to use a knot pusher, but now, because of technology, you don't even need to do that. Just throw it in there and keep passing. And this is what it looks like. This is what it could look like. So this is a vicryl stitch, it's an absorbable stitch. Throw a couple of stitches around something cylindrical and then pass this knot over the top of the scorpion, which you'll see very soon. It goes on the neck, and then once it's on the neck, then you can imagine you take a single shot with your stitch, you pass that stitch over the top of it, and it creates a sliding knot for yourself. You guys get the idea. This just goes into the knee at this point once it's loaded through that small incision. You visualize arthroscopically with the scope, with somebody helping you with retraction, fire your first stitch in the apex, and then just keep alternating between sides. Sorry, it's so wonky. Can you all see this? So again, simple math, 7 would be enough. I usually go with a 67 millimeter graft because then I'm not taking too much, I'm not taking too little, and usually it ends up being excellent. Today with this guy who's a little taller, I'll take a little more, but nothing crazy. And now this is what it looks like in real time from beginning to end. Hopefully this will work. Transverse incision, get through your fat, resect your fat. It's a 3 centimeter incision transversely. Once your fat is released, then you'll be looking at that crural fascia. Fat does come out like this on block, and if you can get it out like this, it's a lot easier to get all the fat you want. And you'd think that with that missing from your knee that you'd have like a big indentation, but you don't. I send a lot of my ACLs to Cindy, so she can tell you. But that is how much I take out. In fact, it's actually the opposite. People will develop a lot of scar in that area, so they'll build up their incision instead. An Army Navy goes in. The Army Navy allows you to retract anything that's above your scope, and then you have a really beautiful view of the quad tendon. Then I'll take a marking pen, go up above, mark exactly where that convergence is, measure it to make sure I'm getting enough graft. This is not a step I do, but you can mark where you're going to go. I then introduce my knife. I know where I'm going to be, stabilize the knee. The knife is also measured, so you have gradations of how much length you're getting out of your graft. So I'll go to 7, release it off the patella, throw a stitch here. This stitch will allow you to really control the graft and pull. After that, I will take a periosteal elevator and release those edges up and down the graft, and then I will use a different instrument. This is called a Graft Pro. I use something called a cigar cutter, which is that first instrument I showed you guys on the first slide. And as long as you can get the head of the cigar cutter in, it's all the incision that you need. this goes in and amputates it at whatever predetermined length you'd like. And then that goes to the back table. Pretty reliably, it ends up looking like that. Clean off the muscle, go back in with the scope, find your edges, and then suture that closed. And it doesn't take that long, so 10 minutes, pretty minimally invasive. I use, like I said, a dual button construct, so I'll put an endo button on the femur, and then I will drill, so partial tunnels on both sides, no full tunnels, and then I'll come with a button on the tibial side at the end of the case. This is just how we do it. This is called a fiber tag. It allows you to have really nice symmetric graft, and you can contour both edges of the graft so that you have nice tubularized shape so that it doesn't pass into the tunnels very difficultly. It's an adjustable loop. It's really, really strong, and you're going to see the next slide will show you how strong it is. It's going to show you my Mentor X being pulled off of the table just using this construct. Oh, well, it'll be on the next slide, sorry. But this is just basically showing that the data has showed that people say it's not strong enough, but the data does not support that. It's very, very strong. This is him again being pulled off the table just using that tightrope. So very strong. More data suggesting how strong it is. This is just whip stitch versus fiber tag. The whip stitch is much weaker than the fiber tag. The last thing I do is I tubularize my graft with these graft compressors. There are these silicone tubes that you can just leave the graft in while you're prepping the notch. I have found that it makes this beautiful, like cylindrical, uniform graft that becomes very easy to pass through tunnels of whatever diameter you've selected. Well, I guess I can show you what it looks like since it's not in the picture. And then it allows you to contour your graft. But at the end of prep, it will just sit on the back table in this tube, awaiting introduction. And then it looks like this. This is what the knee looks like. So this is the transverse incision above the patella. This is the anterolateral portal, anteromedial portal, and I use a far medial portal so that you can introduce the graft into the knee instead of using a massive tibial incision. And then this is the tibial button incision. So all like very small, pretty easy to hide incisions. My mentor used this expression, like what incision would you want your daughter to have? Which I don't know if it would work very well up here, but it was in Georgia, so you could really say a lot of things that wouldn't really be okay up here. But he always said that to like everybody. What kind of scars would you want your daughter to have, or son, or whoever? But they're much more appealing cosmetically. Revision rates are pretty low. Overall, his data, he's had over 3,000 collected cases in the past 10 years. 10% revision rate for primaries, and then the contralateral side, this is interesting, is about 12% involvement rate. So everybody I talk to them about three things. One is how much scar you're going to have in the notch. We don't necessarily need to go back in, but sometimes we do need to go back in to clean it out. Two is there is a revision rate associated with all ACLs. This one's pretty good. It mimics the data that's in the literature, so about 10% rate of revision, and then about a 12% rate of contralateral knee involvement. So just because you had one, it does put you at risk for having another. But all these results are similar to the moon data for PTBs. This is just a chart that basically is showing the morbidity of all three of the graft types that I've talked to you about. I'd say the biggest issue is, for me, cosmesis, strength of graft, and then anterior knee pain. You'll see the only thing that's really heightened is anterior knee pain in BTBs, and then you can have a pretty nasty hematoma from a quad graft. That's the The only complication I've seen besides for or failure is a post-op hematoma, and I have seen it once. And it's not good. The ways that you can avoid it, though, infection rates are exactly the same across grafts. But this is how you avoid complications with a quad graft. One is you don't want a scar, so early aggressive extension, and then getting quads back will help to get you back to full motion. Hematoma, if you take too much graft length, then you are getting into risk of hitting muscular perforators. So as long as you're taking a graft that's less than 7 centimeters, you should be fine. There's really no post-op deformity. I have seen one time a kid who actually popped his quad tendon after his harvest months out. I think he was 8 months out, and he did have a little bit of a migrating worm in his thigh. But again, an N of probably over 500, I have seen only one contour deformity and one hematoma, and I've never seen a compartment syndrome. So the complications are pretty low, the incisions are pretty nice. This is just a side-by-side of a BTB versus a quad. I would prefer that one on the left, as long as the results are the same, and the data has been suggesting that they are, so I'm going to stick with the one on the left. And this is my little guy. You got to get him back on the field somehow, and as quickly as you can. Thank you.